Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, we're going to talk about another couple primary benign bone tumors, and that's going to be the osteoma and the osteoid osteoma. We're going to talk about how to compare and contrast these. Again, these are a type of primary bone tumor, meaning they typically arise within the bone themselves, versus a secondary bone tumor, which is a metastases from somewhere else. These are also considered benign, meaning they don't typically metastasize to other areas or invade tissue in the body. Now, when we think about our epidemiology here, we talked about these being a type of benign bone tumor, which is important to keep in mind for when we talk about later on in the series are malignant bone tumors. When we think about the osteoma, this is something we'll classically see in middle age. So we're kind of thinking that 40 to 60 age range versus the osteoid osteoma, we're more likely to see in a younger patient population. Again, I say this every time. This does not mean we can only see this in this patient population, but most classically, when we think about board style questions, we want to think about classic presentation. This is typically the age range they'll give you for these questions. Now, when we move on to the presentation here, this is where we really start to differentiate these pathologies. The osteoma is typically going to be seen on the surface of facial and cranial bones. It's often going to have an asymptomatic presentation, and that it could just be a finding that's seen on imaging, but not what the patient came in for, or the patient doesn't have any actual symptoms of it, but they know that they have it. Additionally, it's associated with Gardner's syndrome, which, if you recall, is a variant of FAP, or familial adenomatous polyposis. If you recall, FAP is an autosomal dominant condition due to a mutation in the APC tumor suppressor gene. This can lead to a significant amount of polyps in the GI system that have a high risk of malignant transformation. Now, when patients have this condition, and they also have osteomas in the body, this is considered a variant of the FAP, and we call this Gardner syndrome. So it's essentially FAP with bone or soft tissue tumors in the body as well. Now, if we contrast that with our osteoid osteomas, we see the location is likely to be different. These are more likely to be seen in the metaphysis and the diaphysis of the long bones. Again, the diaphysis is the long portion of the bone, the metaphysis is kind of the middle portion, and then the end is kind of the epiphysis of the bone. Now, another couple key points about the osteoid osteoma is that the pain is typically worse at night. And a high yield thing that I really want you to know, because it helps us contrast with another pathology, is that the symptoms are typically relieved by NSAIDs. Why is this so important? Why did I include a high yield? Because there's another similar bone tumor we're going to talk about in another video called an osteoblastoma. And in this bone tumor, pain is not relieved by NSAIDs. So again, it's a very classic way that they like to ask this question, which is why I'm highlighting this. They'll talk about a bone tumor, they'll make it very obvious that's what the patient has. But then they'll have that little caveat somewhere in the question stem. They'll say patient takes NSAIDs or anti-inflammatories, and it does improve their symptoms, more indicative of an osteoid osteoma, or it does not improve their symptoms, more indicative of an osteoblastoma. This is a key differentiating point, which is why I'm highlighting it here. Now, when we talk about the diagnostics here, we have the osteoma, which you can see over here, and this is most commonly going to be a hyperdense, well-demarcated, smooth, bony mass. So you can see this area right here. It's hyperdense, so it's really white on imaging. This is a CT scan that we're looking at. It's well demarcated, right? It's very circular in its appearance, and it's a smooth bony mass, right? It doesn't have a bunch of jagged edges. It's a very smooth circular appearance. Now let's contrast that with an osteoid osteoma, which we'll also look at on CT scan, and we can see it over here, which is going to show up more as a radiolucent osteoid core with surrounding perifocal sclerosis. So what's that mean? Well, we have this mass over here, right? We have the arrow. We have kind of an osteoid core with sclerosis around it, right? This white area is sclerotic and it is surrounding the tissue. And so you can see that pretty clearly on the imaging here. And here is another key differentiating point. Again, osteoid osteoma and osteoblastoma, they like to ask you about those two because they're very tricky. We talked about the difference in NSAIDs, right? Now here's another key point in that osteoid osteomas are typically going to be smaller than an osteoblastoma. Osteoblastoma, I think of a big blast, right? It's big, it's an explosion. I think blastoma equals big. That's typically going to be greater than 2 centimeters. But here in the osteoid osteoma, it's smaller. So it's typically in that smaller than, or it's typically less than 2 centimeters on imaging. Again, they might give you this in a question set. They might talk about the imaging. They might not show it to you, and they'll talk about the size of it, and they'll want you to differentiate the osteoid osteoma versus the osteoblastoma. Now, when we move on to our management options here, for an osteoma, you typically will take it out surgically if it's symptomatic and extensive. Again, a lot of these primary bone tumors, if they're not causing any symptoms, they're not a big deal, right? It's really if it becomes symptomatic that we start having to treat them or remove them from the patient, or in some of them that we worry about malignant transformation. When we look at the osteoid osteoma, we talked about the importance of anti-inflammatories for symptom management and that these do respond to anti-inflammatories versus the osteoblastoma, which does not. And these patients can also have surgical removal as well if needed. Again, if it's asymptomatic, it's not causing problems, we don't go chasing it. We don't go and do an interventional thing. if it's causing symptoms, then we have that discussion a little bit more with our patients. Now, a possible question stem they could ask you about to really talk about some of these pathologies includes something along the lines of a 21-year-old patient presents to the clinic with a chief complaint of left knee pain that is worse at night. The patient denies any symptoms of illness or known trauma to the area. On physical exam, there's a palpable, painless mass above the lateral joint line, and radiographic imaging shows an approximately 2-centimeter radiolucent core with surrounding hyperintensity. The question can then ask which of the following treatment options would be most useful for helping this patient's nighttime pain. Well, the answer is going to be the anti-inflammatories, right? They talked about the imaging. We said it was 2 centimeters, so it doesn't really give you a clear differentiation. Is this osteoblastoma versus osteoid osteoma? It's right at that 2 centimeter mark. But what the imaging does tell you is that there's a radiolucent core with surrounding perifocal sclerosis, or the hyperintensity, right? This white stuff around it, this hyperintensity, is this key defining feature of the osteoid osteoma. We know this is a tumor that's responsive to anti-inflammatories. So when asked about treatment options, we always want to start with the most conservative thing. We would consider anti-inflammatories in this instance. Now, just a quick review of this video. We're talking about osteomas and osteoid osteo. These are both primary bone tumors, and they are benign bone tumors, right? They're not typically malignant. They don't spread throughout the body or get into the surrounding tissues too much. We have the osteoma, which is typically in middle age, versus the osteoid osteoma, typically in a younger patient population, but not always. We have the presentation, which is different. The osteoma is typically in the facial or cranial bones. Key association here with FAP, which we call Gardner syndrome, if they have the combination of FAP, the colonic polyps, with the bone and soft tissue tumor findings. Contrast osteoma's facial and cranial involvement with osteoid osteoma's metaphyseal or long bone involvement. Again, different locations to differentiate these tumors. When we think about the diagnostics here, right, the osteoma is going to have that hyperdense, well demarcated, smooth area, versus the osteoid osteoma is going to have the radiolucent osteoid core with the surrounding sclerosis, or the white area, the hyperintensity on imaging findings. When we think about the management here, again, with these primary bone tumors, if they're asymptomatic, we don't worry about them. We don't go chasing them. But if they are symptomatic, you can consider surgical removal. Key point here for osteoid osteoma to remember that this is responsive to anti-inflammatories. Why is this important? Because we're going to talk about contrasting it with a different bone tumor in an upcoming video, the osteoblastoma. Osteoblastoma is not relieved with NSAIDs. Osteoblastoma, again, blast big, is typically greater than 2 centimeters, versus the osteoid osteoma is relieved with NSAIDs, and it is typically smaller, typically less than 2 centimeters. So these are a good way to differentiate these in your mind as key defining characteristics.